welcome back. The next section of our agenda, we have three groups who will be presenting, and I'm going to ask that each group do their presentation, and then at the end, we'll pull all three up to the front, and we'll have an opportunity for some questions. So we're really fortunate in the Southwest here to have had, as you've heard many times this morning already, three hospital organizations who volunteered to participate in the Provincial Indicator Project. And they did this without any new resources and just the excitement that they had within their organization. So we heard from Dr. Liu this morning in her presentation that we are going to be looking forward to receiving that report, summary report of the findings, and that should be coming out soon, so we're excited about that. The hospitals who participated will be sharing their experience on the delirium and the functional decline indicators. So unfortunately, Grey Bruce is not here, but they did prepare some slides for us, and Jillian is going to present those on behalf of Grey Bruce.
Thank you. Unfortunately, as Kristen just mentioned, Grey Bruce is not able to join us today, but they have sent information to share with you, and I have a few names. They'd be happy to answer any specific questions you might have regarding how they rolled out the screening tools for delirium and functional decline. So, for some context to their organization, Grey Bruce Health Services consists of 6 hospital sites with inpatient and outpatient services, and their largest hospital is in Elgin, and that has 169 beds, and their smallest is Lions Head with 4 beds. And they may note that they have a large senior population within their catchment area. On your way. So they rolled out tools for both delirium and functional decline at their organization. For functional decline, they did use the HOBIC tool that Dr. Barbara Liu talked about this morning. And the reason they decided to participate and to evaluate this tool was because they had been using this tool prior. This wasn't something new for their staff. They were familiar and comfortable with it. They used the HOBIC ADL assessment on admission and discharge, and it is an electronic document for them. They also implemented a check sheet that the physiotherapist had designed for them, and it was in every single patient room. And physio staff, as well as all the other staff involved with patient care, kept track on the sheet of their patient's mobility. And they felt that this was a great way to encourage patients and to hold that data out for the purposes of this assessment. There were challenges for them. The HOBIC tool is automatically generated on admission charts, but they had to learn and remind themselves to generate it for discharge. So compliance was lower with the discharge tool. That's there. Lessons learned. They feel that through this participation, there's no better awareness by staff of the importance of mobility and ADLs. And they made note that they used this tool prior, but they feel like they're better at it now because they really put a focus on this. They've continued to use the HOBIC tool on admission and discharge since completing the 6-month evaluation period. And they continue to use the check sheet that they implemented at the patient's bedside. And they feel that that's an effective visual for all those providing care, patients and families themselves. They rolled out the CAM tool for screening and detecting delirium. It was implemented on their medicine floors hospital-wide at Grey Bruce over a year ago. So again, this wasn't a tool that was new to them. They had all received education on that. So really there wasn't any great challenges for them with rolling this out. This was not an electronic site, so they dedicated a ward clerk to collect all of the all of the assessments at discharge for the patients to look through to see whether there had been any positive screens during their time. And they spoke to this being a bit more time consuming because they do the CAM tool on every patient, but for the purposes of the study, they were looking at only those over the age of 65. Nurses have used this tool, so RNs and RPNs, and it was done daily between 2 and 3 p.m. And they discussed it at daily rounds. And in some patient rooms, they made mention that they have whiteboards, and on the whiteboards, they would put a positive or negative. Didn't have any information in regards to what that meant, but for staff, they were aware of what that would mean. For lessons learned, they felt that there's better awareness. Challenges. So their challenges were that it's not electronic, so they did need additional support to capture this data. And staff received refresher training. However, they made mention that there's always the challenge of identifying delirium versus dementia when you don't know your patient's baseline. This has changed, but lessons learned tool is quick and easy to administer, and they found that they were all having more discussions about delirium as a result of incorporating this into their practice. All from Grave Bruce. I can certainly provide names. Jane Kepi assisted me with the preparation for these slides, as well as Donna Chappelle and Jane Wilden. And again, they'd be happy to answer more.
Okay, so now I'm going to invite Christine Thompson and David Simpson up to join us. Christine is a manager of acute medicine, and David is a manager of complex continuing care, both from St. Thomas Elgin General Hospital, and they participated in the project as well.
Hello. So we just started here with the definition of senior-friendly hospitals. We put both indicators up here. We've participated within the project of the functional decline and the delirium. On the medical unit, I did the functional decline, and David over in CCC did delirium. Within our hospital, we have 2 medical floors. At the time, we thought we would just pick one unit to do the project. So we decided on our 4th floor medical unit, which consists of 20 inpatient beds with the opportunity of 2 overflows. So we had to go up to capacity to be 22. There's 4 registered staff that work on the floor, so we have a 1-to-5 ratio, and 1 CRN that works for that. On the floor, we also have 1 full-time OT PT and a PT/OT assistant. And also, when we started this project, we just implemented OT PT treatment room on the 4th floor, and we have 1 palliative room. So, developing the process, we weren't really sure how it was going to work, but we just thought we'd start somewhere and see. So we used the Barthel index, and thought the best thing would be was for the unit clerk to put a patient sticker on a Barthel index and put it in a binder every day on every admission. We solely picked the therapy staff that they'd be completing the Barthel tool. So each morning the therapy staff would review the binder, and if there were any exclusions, they would remove them. So the OT assessed and recorded all the scores for the ADLs. The PT assessed and recorded scores for transfer and mobility, and then they had input from nursing for bowel and bladder. So we did our study from June until the end of November, where we had a total of 398 patient admissions. Now the data, when we pulled it, we were kind of disappointed. We didn't feel it was going to show this, but it did. So 143 patients were excluded because of the exclusion criteria. what we found disappointing was when we got to 165 data incomplete and no reason for the exclusion. So really in total, in 6 months, we did 90 patient full assessments. I'll get to why we were the incomplete and after the exclusion. So over the 90 patients, we only did have 2 patients that had a functional decline, so we were very impressed with that 98% either maintained or improved their mobility. Our average score on admission was 61, and on discharge it was 73, and the average patient population was 79. So the strengths. So we felt the strengths were that we involved the therapy staff right from the get-go. They're the expertise in that area. They're the ones that should be completing it. We also thought it was a strength that our floor had 1 full-time PTOT and assistant that worked on a consistent basis with these patients. Definitely a strength was with the treatment room gym on this floor. We've been trying to get a gym treatment area on the acute side forever, and it finally happened. So that was a big strength for us. And also our multidisciplinary team approach. We have whiteboards at every patient bedside that the therapy staff would fill out for mobility, how they were transferring. And also we do daily patient bullet rounds every morning and talk about the patient, and PTOT is there. So limitations, at the time we were short-staffed in the therapy area, so they found it difficult sometimes to get it completed within the 48 hours. If there were admissions on Fridays, it wasn't completed until the Monday, so we were over the 48 hours. We only have 1 PT and OT that worked the weekend throughout the whole building, and that wasn't a priority. The priority was to see the patients and provide the treatment. And also the discharges on the weekend, if that happened, it was the same thing. The therapy staff wouldn't complete them. And then the inconsistent identification of admissions. So this is where we think that 165 or 163 number came from was, I think most of the full-time work clerks would be following this process, but when the part-time people were on, this necessarily wasn't done. Therapy staff weren't checking our census book as opposed to the Barthel index forms that were put in the binder. So there wasn't that approach to make sure that each patient did have an index there. So, but we were very happy with the outcome that we only had 2 patients that had the functional decline. So that's what happened.
Just to start out with, I'll give you a quick overview of the complex continuing care unit at the Elgin General. During the period that we were doing this pilot project, there were several things that were happening in the background. We were going through a process of bed realignment, where beds were being realigned across our limb. So that meant for us a loss of 15 complex care beds. And so we were dealing with the staff around that and fear of job loss and educating the community and patients and families. At the same time, on October 1st, we also implemented coordinated access, which meant that our beds in complex care and rehab became system beds. And so the process for accessing those beds, in fact, changed as of October 1st, so that if we had a patient on Christine's unit that needed a bed on my unit, we would go through what's called coordinated access. So they would make a referral to Community Care Access Center. CCAC would then meet with the patient, do their assessment, determine eligibility, and then wait list the patient. And when I had a bed available, if I accepted the patient, then the patient would come to my unit. So we also had that going on at the same time. And we were also preparing staff for Hugo, the electronic patient record. Everybody laughs because you know what that's all about. So that was kind of the context and the backdrop. It also meant we went from being a 55-bed unit to a 42-bed unit. And the breakdown there is 30 complex beds and 12 rehab beds. And that 12 rehab beds was an increase of 2 rehab beds for us. We went from 10 to 12. And the patient population that we had in CCC is either rehab or complex. And in the complex patient group, we also have the end-of-life patients. So we really have rehab, complex, and end-of-life patients on the unit. So we decided during the pilot project that we would print the CAM on bright green paper, and we would put it in the bedside chart where all the flow sheets were kept, so that in fact people would see it there and remember to complete it. And we also talked about it at our morning huddle to remind people to do the CAM, please do it. And the CAM was actually put into the admission package on our unit, so that bright green form was right at the front of the admission package. And it was in every admission package, even though there were some exclusion criteria, and the project really was to be, the CAM was to be administered with patients age 65 plus. So where the patient met the exclusion criteria, they'd actually put that on the form, and if they were under 65, they would just put a line through the CAM, leave it in a chart, so that at the end of the month when we collected and submitted the data, we had information about why people were not included. We did the CAM on one side of the green paper, and on the other side was the daily charting, where they could say if the person was CAM negative, CAM positive. And our CAM was only administered by RNs and RPNs, just the nursing staff. And we did it every day around 2 p.m. in the afternoon. And then every month we would submit our reports to senior frontline hospitals. So our pilot project ran from early June to December 15. During that time period, we had 125 admissions. 11 patients were excluded, or about 8.8% of them. There were 1,929 total number of days of stay for those who were not excluded, and 1,795 CAMs were completed. 93% was the percentages of days where one CAM was completed. We had one CAM positive on admission and 4 during the pilot project period. And the age for us was 79.5 years of age. So the exclusion criteria was just that the patient was in palliative care, or patients whose level of consciousness was unresponsive or requiring vigorous stimulation for a response. We did have, as a team, lengthy discussions about palliative care patients, because we have patients that in the old days we would call them complex palliative, that were with us for extended periods of time. And should we have in fact been doing the CAM with that group, because in fact delirium may have been indicated with some of them. I'll just go through these next couple of slides really quickly. This is just the CAM, the questions in box 1, questions in box 2, the scoring of the CAM, and some of the foreseeable outcomes that we're looking at during the pilot project period. So we're just looking really at the improved cognitive and physical function, knowing when to offer people different programs, when to involve them, when a good time of the day was, and when it wasn't such a great time of the day for them. The positive here, and I'll get into this in a minute with the strengths, this pilot project really facilitated a discussion about delirium, dementia, depression. Our nurses have used the CAM before, historically, and so they were aware of it, but it was a great opportunity to talk about prevention and treatment. The CAM is really easy to administer. It only takes a few minutes. Our documentation requirement was very simple, which I think helped there to be greater compliance. And the other strength is that throughout the process, the staff talked to each other about delirium and the patients and sharing information. And we would often identify people where we thought delirium would be indicated, and really develop strategies around that. Some of the things that were lessons learned for us. We only administered the CAM once daily, And the nursing staff felt we should have done it twice a day to capture more reliable data. So that was feedback from the people who were actually administering it at the bedside. And we had actually talked at one point about, do we stop this pilot and then restart it doing the CAM twice a day? Because there were times, in fact, when delirium might have been present after the CAM had been done for the day, and by the next day there wasn't any evidence of that delirium, that in fact things had progressed. The other challenge we had too was our schedule. Some of our nurses work what we call a waterfall schedule, where they do day, day, night, night, then they're off for 5 days, and then they repeat that schedule. So they were absent from the workplace for that 5-day period, and some of them, there'd be admissions during that time. They didn't really know the baseline of the patient. And so that staff schedule had the potential to impact as well. And so there was a need for better baseline data. We'd have a patient transfer just maybe from another hospital. We'd never seen the patient before, and how they presented on day one. There was a need to continue to repeat what they were like at baseline. More education for staff and patients would have been helpful, especially with families. What are you doing? Why are you doing it? What are you looking for? What are you going to do if you find it? Those kinds of questions. And last of all, I think the pilot project was very helpful in raising awareness. We're just starting to prepare now for accreditation for next year. And so Christine and I have been talking about, do we put the CAM into the admission package for every patient who comes into the hospital? And how do we, in fact, use the findings from our pilot project to make sure, in fact, we're a senior-friendly hospital?
Wonderful, thank you. Don't go too far. Thirdly, please welcome Beth McCarthy. She is the director at St. Joseph's Healthcare London in the Specialized Geriatric Services Program, and she will share St. Joseph's experiences with the Indicator Project. Thank you.
So I have to say that I'm filling in today for Lucy Ormsmith, our occupational therapist, who was quite a leader on this project on our inpatient unit. And she is suffering a terrible summer cold and is at home, I hope, drinking chicken soup and feeling better. So she was very distressed she couldn't be here today. Oops, that's not going forward. I'm sorry. Oh, there, whoops. Go back. All right. There we go. It's very fun. All right, so just a word about St. Joseph's Healthcare London. We're coming today from the Parkwood Hospital site. And the Parkwood Hospital site provides rehab. So we are a non-acute site, which is important because you've heard from others who are, and certainly Dr. Liu spoke very briefly this morning about the experience of rehab, which was different, I think, than acute care sites for sure. Our RGP program has been championing this work since 2011, or perhaps before, but more formally since 2011. And when there was a provincial call looking for hospital locations, we knew that we wanted to participate. We just weren't too sure how we would fit because we were non-acute. Right, here we go. So once the decision was made, it was the SGS programs, our inpatient programs, that we decided we would pilot this. And Dr. Wells agreed to be our principal investigator. So we assembled our team, and we had to make a decision right at the very beginning about who would be on the team. And so that was a bit of a discussion on the units. We thought we would do it a bit differently than we tried before. We completed the ethics application. I have to say that was a personal learning experience for me. I heard that it was a lengthy, cumbersome process. And even for this very simple project without any budget and with no patient identifiers, we still took 4 months to get it through. So I kept in touch with Toronto and kept saying, we're almost there, just hold on, don't go without us, we're coming. And we eventually got there. So our occupational therapists made up our team primarily, And they reviewed to get ready the senior friendly toolkit and all of the materials related to the CAM tool in preparation for data collection. And although this was known, everybody in SGS we think knows what the CAM tool is, it was an interesting experience to actually start to operationalize it on our units. And we found that there was quite a learning curve to go back and become more familiar with it and to actually operationalize it. So we have 30 beds on the geriatric rehab unit and 20 beds on MSK. Our focus is really on maximizing independence and preparing people for discharge home. So we have a multidisciplinary team approach in place, and that team is active every day, working with our patients. And each patient identifies rehab goals, and we're very focused on this is a rehab setting. So you'll be up, you'll be out. Before you get to us, bring your running shoes in, get your family to bring them in, get your track pants, you won't be laying in bed. So we were really curious about how all of this would work with us. Each unit also has a rigorous falls prevention program in place, which again speaks to maximizing independence. We walk that fine line. We want you as active as you can be. We want you as safe as you can be. So a lot of interaction every day with every patient around anything that's changed from a safety perspective, because when we're mobilizing people, we want to be sure they're safe. So there's already a lot of assessment that's going on by all of our team members each day. 85% of our admissions come from LHSC acute care and medicine and surgical floors primarily. And that's following an episode of illness, injury, or surgery, and then 86% of them go home. That's right, yeah. So the 5 occupational therapists work right across the 50 units, and they each have a portion of those patients. And that is an indicator of who else was on the indicator team that we assembled right at the very beginning. We also, like St. Thomas, and participated in the monthly webcast by the Toronto RGP, and both found those very, very helpful in being able to sustain the project and as a place to take our questions. And early on, there were many, many questions because we knew we were a bit of an outlier with our rehab population. So once the patient was admitted to our unit, and an OT is automatically assigned depending on what bed they go into, the OTs then completed that CAM right at their very first encounter with the patient. So in most instances, it would be the first day. They also had a little bit of challenge because of not having the baseline, but quickly found that they could, in their early discussions with team members, were able to fill that gap quite quickly. They then completed the CAM weekly. So we made a decision, it didn't make any sense to be doing this daily on our unit, so they did it then weekly until the patient was either discharged, or in a few instances, if the patient became ALC, at that point they were discharged, and we stopped doing the CAM. There are some questions about that, but it had more to do with the OTs and just the schedule that they have then about being in touch with those patients and who else would be seeing the patient. If we're going to do this, we probably do it a little bit differently. Again, the tracking sheets were something that we were given by the RGP of Toronto, and then we then tailored them really to fit our unit. And the tracking sheet, once they were done with it, they kept it right for the patient's stay. When the patient was discharged, they then handed it over to the secretary on the access office, who then completed the sheet that we submitted monthly to the Toronto RGP. This did not preclude other team members. This is an important point because early on, the team who automatically are very concerned about continuing to monitor their patients along and maybe seeing something a little different and questioning it, is there something going on, your patient's status has changed, maybe we should be checking for a UTI, something, patient's a little bit off today. We wanted to be sure we didn't lose that. And so we had to go back and say, there were some questions from nursing about, so now we're, if we see this, we're supposed to let the OT know, or what's supposed to happen? No, business as usual. If you're seeing something, bring it through the usual course, make sure you're identifying it, you're doing what you would usually do, usual treatment and care, and we're nipping those right in the bud. We don't want them to sit and wait for a week. The data collection began on September 9th and went to March 31st, and we collected data on 243 patients. Of those, 11 had a positive CAM score at admission, 7 were found to have a positive CAM score at discharge, and 5 of the 7 patients were the same who'd been positive at admission. And when we looked at those patients, they were patients who came to us that there was some medical instability right at the time of admission, and they usually weren't with us very long, and they ended up going back to acute care for some follow-up reason. We saw this as a great opportunity for our inpatients to participate in this work, and particularly research. It's always a challenge within our program of SGS as frontline staff really want to be involved with research, and our resources and time really limit their ability to be involved with that. So when this came along as a tailor-made research project, we just knew that we would have a lot of excitement, and sure enough, the OTs were very excited to participate and really felt that provincial connection was quite positive for them. Noting changes in patients that negatively impact functional independence and addressing those as a team is part of the geriatric work, the teamwork anyway. So we did struggle with how would this fit into our world on an everyday basis. And we thought that, again, it emphasized for us the difference with acute care where patients will be fluctuating, the staff, as you talked about, will be moving through, and it makes perfect sense to be doing it more frequently. In our case, the same teams involved with that patient from the time they hit our floor to the end. Nursing, of course, will move through, but even there, they're on for 2 and 3 and 4 days at a time. So very much a different atmosphere on a rehab floor than acute care. And we didn't think the camp fit with geriatric rehab all that well, where the team members are focused on functional independence with the goal of discharge home. We were picking that up, we think, much more quickly. And that had been why we had not had great success in the past with implementing camp